Уважаемые дамы и господа, уважаемые коллеги, меня зовут Дильмурод, я из университетской клиники Цюриха. Благодарю за возможность предоставить наш проект о презервации печени в течение одной недели с помощью интегрированной машины. Я уже много лет на русском не общаюсь и боюсь, что плавно презентовать на русском не смогу. И из-за этого, с вашего позволения, переключусь на английский язык. Life outside of the body is a fascination that we scientists want to understand since centuries. Every progress in the field deserved huge attention from scientific community. The pioneering work belongs to Carrel and Lindbergh. They perfused in 1938, first time the organ outside of the body, and they deserved time coverage. Even after centuries, the topic is still hot. Recently, a group from Oxford perfused 9 hours, human livers and transplanted. They deserved nature coverage. We did a breakthrough in the field. We could extend preservation of the organs for 1 week, which was published in Nature Biotechnology. In reality, organ preservation started with machine perfusion. Later, we have learned that we can preserve organs in cold storage. However, recently, the interest to machine perfusion is revisited. The reason is dramatic organ shortage. With the machine perfusion, we want to improve organs and repair them. The currently available machines for human use is allowed to be used only for 24 hours. The next step is also long-term preservation. Long-term preservation could increase the number of transplantable organs in several ways. For example, ex vivo liver regeneration. During ex vivo liver regeneration, you can split one donated graft to several pieces depending on anatomy, regrow them outside of the body, and transplant to several recipients. Another option would be repair of injured organs in ex vivo machine. As you can see in this slide, any transplantation has ischemia reperfusion injury. After it declines, body tries to repair this injury, and usually it takes time, at least several days. Therefore, if your machine can perfuse only for a few hours or 1 day, you don't repair this organ. You cannot see the repair process. Therefore, you need a long-term machine to make injured organs transplantable in ex vivo setting. We have created this machine. The machine imitates the body. It has integrated lungs, which can control automatically blood gases and pH. It has dialysis unit. It has artificial pancreas. We imitate intestine with infusion of nutrients. It imitates also physiologic saturation in portal vein. It has pulsatile flow and as usual, buffers and reservoirs. This is an overview of this machine. Please note this dialysis unit. This is a yellow with blue caps. I will come to this unit. You see how small this unit was integrated in our perfusion machine. We had several halts during development of this machine. Due to time reasons, I cannot explain all of them and then refer to our publication in Nature. And to highlight 3 main features. This is a loss of glycolic control, perfusate quality, and pressure necrosis. And this is a schematic overview of our perfusion machine that I described previously. You can see that the machine even provides physiologic portal vein by mixing arterial and venous blood to the portal vein. This has also very relevant physiologic significance, because if you have very high amount of oxygen in portal vein, hepatic artery reacts with vasoconstriction. This paper was also accepted recently and published. And this is not one-man show. Behind this perfusion machine stays 44 years of the work of 13 people. We used at least 70 peaks to develop this machine. And first we started with glucose hemostasis control. Current standard during liver perfusion is to provide hyperglycemia in perfusate, which is used also in a human setting. Unfortunately, with this established protocol, we induced glycogen storage disease in ex vivo setting. You can see the histology on day 3 with providing hyperglycemia and insulin. The hepatocytes became enlarged and pale. We have tried in the next step to control it manually, but failed. And afterwards, our erythrocytes exploded. As you know, erythrocytes lack mitochondria and they need glucose as energy source. If you don't have glucose, they start to die, erythrocytes. Engineers saw this problem and challenge and integrated an artificial pancreas into the system. You see how it works. This is a target line dotted, and then if glucose goes up, system starts to inject insulin. If glucose falls down below the target, and then it stops. If it goes further below, it can inject also glucagon, so liver reacts and releases glucose. With this one, we could maintain glucose level at constant level, and then we didn't have any changes similar to glycogen storage disease, and our erythrocytes were safe. The next feature is an integrated dialysis unit. During perfusion, we provide several medications, nutritions, and it caused hemodilution. It's understandable if you have only 3 liters of perfusate. And then the engineers integrated this dialysis unit, and the dialysis unit adjusts outflow and inflow, maintaining hematocrit at constant level. And as you remember in ICU, and you see it always every day, dialysis unit is a big machine, and they could compress to the small one that I showed previous slides, so it's didn't take such a big place in our machine. Furthermore, this dialysis unit could control electrolytes level. You see in the blue line, sodium level without dialysis integrated, and then red one with dialysis. I don't think that we see in a clinical setting sodium level 200 in a patient. I think it's impossible, but we have perfused without dialysis, having such a high levels in livers with death afterwards. And then dialysis also corrected this sodium level. The next one is a pressure level, pressure necrosis. After 10 hours of perfusion with the previous machines, we had a pressure necrosis. Therefore, we have simulated the diaphragm, which prevented this necrosis. In science, we need to be objective, and we did a PET scan after 1 week of perfusion, which showed homogeneous perfusate distribution. Engineers also did their work. At the first step, we had 3 tables with cable salad. You can see this initial setup. And currently, our laboratory prototype looks like that. And we are working now to do it even smaller, so you can take it to helicopter or any jet. And again, it's not one-man show. This is a histology of the liver after 1 week of ex vivo perfusion, and you see here clearly preserved integrity without any relevant necrosis. And perfused livers during the 7 days, they could clear injury markers, they metabolized lactate, they responded to pancreatic hormones, they could clear also bilirubin producing the bile for 7 days, and then they produced ATP as energy source. As a proof of concept, we have transplanted pig livers. You see the Professor Klavian and Dudkowski and behind me and the colleagues who are doing this transplantation. This is a photo of how liver looks like after implantation with histology. And the aim of the project at the end of the day to bring this technology to the patients. Therefore, we have initiated a project for perfusing of discarded human livers after approval by Swiss Transplant and Cantonal Ethics Committee. And then we always asked the next of kin for informed consent as soon as a liver was discarded by Swiss Transplant or by other European centers, and then we put to the machine. Left side, you see all cannulas that we put before perfusion, and then right side during the liver perfusion. And so far in this Nature paper, we have reported 10 livers, and they were in a very bad quality, as you can see in this table. They were DCD, steatotic livers, and fibrotic livers with inflammation or with a very long cold or warm ischemia time. Despite the fact we could perfuse 6 of those livers for 7 days, but 4 livers failed, and they demonstrated continuous cell death, similarly like liver failure. Nevertheless, those few livers that could not be perfused for 1 week helped us to develop a novel viability criteria. As you see, this is a histology after 7 days of perfusion human livers. There is clearly 2 groups. One is declining injury markers, second one cannot, it's very high injury markers. Intriguingly, they both cleared lactate, and bile flow was preserved only in good livers. And the question is it transplantable after 7 days? This is a current criteria which is usually used to assess organs during or after machine perfusion, after normothermic machine perfusion. Those are lactate, ILT, IST, bile production, and normal pH. But those livers, 4 livers that failed 1 week of perfusion, was a ground to establish a novel criteria that includes response to hormones. For example, bad livers do not respond insulin or glucagon. At the end of the day, they develop hypoglycemia like a liver failure. You cannot maintain resistance in hepatic artery. In opposite, good livers, they respond to pancreatic hormones, and you can maintain resistance in hepatic artery. And then you have always integrity in histology, which is not provided in bad livers. And good livers can decline inflammation markers, and they preserve liver functions. If the livers met those criteria, we consider them as a transplantable. If they don't meet those criteria, then we have to discard those livers. And we think that the livers that meet these criteria are viable because they fit to the definition of the life. It is alive when there is a response. It is alive when you have a cellular integrity. It is alive when there is a metabolism. It is alive when there is a hemostasis, and it is alive when there is a growth and development. This was my last slide, and with this slide, I would like to conclude and to state that this study demonstrates for the first time the success of preservation for 1 week with viability. This technique opens the door for novel approaches in the field of transplantation and regeneration. The next step in our project will be to use those rescued human liver grafts for transplantation. Hopefully, we can present those data soon. Thank you very much for your attention.